All right. Our care transitions panel today is represented by Carol Knight. Carol is the Vice President of Senior Housing with Noland Health Services here in Birmingham. They have a fairly large footprint of post-acute care, and Carol, we're delighted to have you here with us today. She has responsibility for 1,583 long-term care facility beds covering 18 different facilities. So obviously a lot of experience and exposure to be brought into consideration there. And they range from independent living to assisted living to skilled nursing, so that covers the waterfront in that particular area. In addition, we have Hollie Powell. Hollie is the Director of Care Coordination and Risk Management with Marshall Medical Centers in Guntersville. She is a social worker by background and currently leads the hospital's efforts to reduce readmissions in their facilities. So it seemed very appropriate that we have someone from within the acute care setting coordinating with the external forces, if you will. So delighted to have both of y'all here, and I'm going to, I guess, join you right over here and get mic'd up. So with that, I think I am supposed to turn it over to Carol, to you, and let you speak, and then Hollie will follow, and then we'll have an interaction as a panel. Okay. Thank you. And you're welcome to this location right there.
I'll stay here. Okay. Thank you for the opportunity to be with you this afternoon. Certainly you've had some wonderful speakers today, and I think that Hollie and I both will touch on some of the very things that have already been touched on. But I wanted to just give you some general information about the long-term care. I know most of us still call us nursing homes. The true CMS name is skilled nursing facilities. So if I tend to use those two terms interchangeably, it is the same thing. What some of you may or may not realize are that nursing homes are now the world's most heavily regulated industry. We surpassed the nuclear industry a few years ago with regulations. Boy, isn't that something? And we have 3 years of additional regulations in the pike. Our first year has already happened, and some of that was sort of catch up with what had happened in other portions of health care. But on November the 28th, we have our second sweeping set of regulations that we must put into place. So a lot of the things about care transitions and rehospitalizations come into play with that. And I'll come back and touch a little bit more on rehospitalizations, but I also wanted to tell you a little bit about the additional regulations that will be going into effect to us. Just as you heard the last speaker talk about the importance of preferences, we're moving to what's called person-centered care, which is what the resident, patient with you, resident with us, would like done for themselves. So we're moving more and more toward that. Once again, in addition to reducing rehospitalizations, it's reducing infection rate, stewardship, antibiotic stewardship. And I've seen a few little packets around today that have been handed out. A huge focus for both you guys and us, which will require us really working together well to be able to reduce that. Reducing medications, unnecessary medications, especially medications that do not have the appropriate diagnosis, or medications that are antipsychotic in nature. So a huge focus on that. You've already heard your speaker talk about the importance of that from a hospital perspective, and that becomes more important with us in long-term care as they spend even greater amount of time with us. The next part was something that we thought, well, okay, this is another thing that CMS wants us to do, and that's disaster preparedness. It wasn't really a big issue when all of it passed, and the idea of working with your local EMS to put things together, but now it's huge. Look what happened in Florida, and look what happened in Texas, so it seems to be very much on the focus. The hospitalizations, I want to come back to that. When Rosemary and Margaret approached me about doing today's seminar, and we talked about various aspects, I said, well, let's look at using AQOF, because AQOF has some wonderful tools. Little did I know that AQOF was helping sponsor today's seminar. So AQOF, thanks for all you've done for the long-term care industry, because there's some excellent tools that have come out of what AQOF has done, and I'm taking a lot of time, so I'm going to let Hollie talk for a few moments, and then I'll come back to the rehospitalizations. Okay. First of all, I want to talk a little bit about what AQOF has done for Alabama. One of the projects AQOF had was to reduce hospitalizations. Alabama was one of 7 states that was part of this project studying 6 diagnoses, and a tremendous job was done on reducing rehospitalizations. What you have as part of your handouts today is some of the tools that were used by AQOF for facilities. I'm not saying you have to use these in their entirety, but I think they are a very good resource to help with that rehospitalization. We too, taking that the next step, the value-based purchasing program will also be affecting us actually a year from now in October of 18, but we're in the window now of what's happening in our facilities will affect us, in that we will all receive a 2% reduction in our Medicare payments, only to be able to earn them back if we show that we have a significant reduction in our hospital readmission rates. So a lot happening on that front. And with that, Hollie, I'll let you talk a little bit about.
At Marshall Medical Centers, what we focused on has been, with our SNFs, has been readmissions. That's how we got to working with them. And we started having community meetings every quarter with our SNFs and with our home health agencies to come together to try to figure out how we could reduce those readmissions and how we could work together in transitioning our patients from our acute care facility over to the SNF or to home health. So we would just bring things to the table and work together. We worked together on a transfer form so that when the patient came to our facility, we were getting the same information through our transfer form from the SNF and also from our home health agencies. We also worked on education tools, trying to make it to where the same education they were getting when they were discharged from the hospital was being continued when they went to the SNF and when they went to home health. Because we felt like that the same education repetitiveness would keep them to understand things, and that would reduce the readmissions. We also began, when we would see a spike in one of our local facilities that was having more readmissions, we would pull those charts from our standpoint and would also meet with their administrators and ask them to pull their charts and kind of do a root cause analysis of why we felt like this patient got readmitted and what we all could have done differently on our side from acute care and from their side from the SNF and home health. And we saw a lot of things come out of that that helped both of us, the hospital and the SNFs and the home healths. That's kind of it in a nutshell.
All right. Sounds good. Thank you. Y'all able to hear me okay? Is it on? Maybe not. Okay. Turn it up. It is not. So now it is. Is that better? All right. Well, thank y'all very much. Let me just throw out a couple of comments, and they may be myths or they may be reality, but I think it's helpful if we can kind of openly discuss this. So again, I'm not trying to nail down any dirty linen of any kind. But I think we've often assumed in the hospital that we have different incentives perhaps than the skilled nursing facilities, that the skilled nursing facilities have a set of measures that CMS is putting upon you, and we have our own set of measures, and maybe those measures are not aligned. And I think you alluded to that when you talked about the readmissions, that y'all will soon be being penalized relative to that. And I think it's often been presumed that the easiest thing might be to send the patient to the emergency room, have the emergency room physician see them. And I guess it would be helpful for us to understand, are you penalized for mortality currently? Are you penalized for readmissions currently? And is there anything wrong with a patient being evaluated in the emergency room and then sent back to the facility? Is there any incentive alignment there that would differ from you than it would be for the hospital, perhaps?
Good question. First of all, we're not penalized for mortality, so those rates don't affect us. And there's not an incentive or a penalty, either one, for sending someone to the emergency room from a reimbursement standpoint. But from very much a perspective of patient care, I think that perspective has changed. We used to have an old saying in nursing homes, when in doubt, ship out. And that's what we did. And the nursing assistant would go down the hall. They took care of the patient every day. They saw something a little different, knew it didn't quite feel right, go tell the nurse, then the nurse would call the doctor and send them out. Just because they looked different. The gut told them something was wrong. What this program that has happened with AQUAF that we've worked on now so much is, it's called Stop and Watch. It starts with that individual caregiver of stop, watch, see what's going on, gather information, take it to the nurse. Nurse continues to gather information, calls the doctor with the information, and then, if necessary, sent to the ER. But I think what we're all trying to do is take care of more of our patients in-house rather than sending them to the hospital. Most of us have added additional RNs around the clock, IV certifications, things like that, so that even if they do need to go to the ER, they can come back and have course of treatment in-house. There's nothing that says, or any reason that a hospital should admit someone if there's not the appropriate medical rationale for doing so. What does often happen, though, is real world. That daughter we were talking about a while ago, that 50-plus-year-old that says, I want my mother sent to the hospital, I want her admitted, I want her on antibiotics, I want this, I want that, and it's very difficult for the healthcare providers in any setting not to move forward when you've got a family member pressuring.
Right. Okay, good. Do y'all keep up with, again, it sounds, I don't know what the right word to describe it with, but do y'all keep up with the fact that they were discharged 28 days ago and there's a magic 30 days that people are counting both for readmissions and mortality, or that's totally oblivious to the average kid?
No. In our organization, we do keep up with the 30 days. We've been tracking for over 5 years our readmissions, but ours is more than that 30-day magical. It's more than those 6 diagnoses that are being tracked by CMS. We look at, as a company, we look at various benchmarks. If we admit someone, the next morning we're looking at all of their care, and if they had to be readmitted back to the hospital within 24, 48, or 72 hours, this red light, so to speak, goes off of, did we admit them too soon from the hospital? Did the hospital send them to us too soon? Did we not get enough communication, exchange of information? Did we miss something? So we start looking at that root cause analysis that you were talking about. We start looking at what could have been done differently. We know that's traumatic to the patient and to the family for them to go back to the hospital so quickly. So it's not that it's magical at 30 days. It's almost like it's magical if it's well before the 30 days, especially if it's in 24 to 72 hours of did the person get discharged from the hospital sooner, or did we miss something in orders of treatment that we could have done in-house?
Okay, thank you. Carol, I'm going to come back to you in just a minute with an engagement of the family part of this question I'm going to throw out to Hollie. And that is, Hollie, you mentioned the new form that y'all have developed and utilized. Can you kind of describe how you're using it and what's on it, and then specifically, are the families involved of the patient that's being discharged as part of that process?
The form that I referenced is if the SNFs are sending a patient to us, the SNF or the nursing home is sending a patient back to us.
So it's the incoming form?
It's the incoming form. And so when they send that, pretty much it's just demographics of the patient, what's going on with the patient, why are they sending this patient. Okay. We do ask that they send the medication list and any other records, you know, their H&P, any clinicals that they can send us, any labs if they've had any of those frequently. You know, we need to know if they're a DNR or if they have an advance directive. We ask them to send that. That's on that form as well. One thing we added, speaking about sending them to the ER just to see a physician, We did add at the bottom that we want someone to sign saying that they spoke to the medical director or that patient's physician from the nursing home that knows that that patient's being sent back to the ER. Because what we were learning is that a lot of times after administration went home, they were sending these patients back, and that physician may not have known that, but our ER physician didn't really know what was going on with the patient. And again, families were coming, you know, we'll just put her on some antibiotics and send her back. But our physicians feel liable for that, and so, you know, they don't know those patients. Our ER physicians don't know those patients well enough just to put them on something and send them back. So we had started asking, would they tell us that they had spoke to a physician? And sometimes our ER physicians will call that medical director of the SNF if they, a lot of times because we're small, they may know them anyway, so they'll call them and question them.
Was that form or these questions relative to the physician, did that come out of the AQUAV Care Transitions program, or that was just something y'all did as an institution?
That was something us, along with, I mean, our SNFs and our home healths at our community meetings decided that we needed to do, because our SNFs and home healths helped us develop our transfer form. We just didn't go out and do it by ourselves. We did it in that community meeting that we have, and so we all took part in that.
Right. So now back to the family side of the nursing home or SNF. It may be that you've got that on this form in a setting like this, but does typically the family participate in the decision relative to the patient going back to the hospital? Are they made aware of that typically?
Absolutely. Matter of fact, the regulations require that the physician and the family be notified, and oftentimes you run into that situation where the family, sometimes you're just calling to say maybe the doctor gave a new order, and you may have a family say, well, I want more than that. I want my mother. And I know from my own family perspective, I've been in long-term care for over 40 years, but when my mother went into one of my facilities, I had the same issue with my sisters. Wait a minute, we don't have to send her to the hospital. We can do that in the facility, but it's still part of what oftentimes a certain age category thinks is that can only be treated in the hospital, can't be done outpatient, can't be done in the skilled nursing, and we've got to change some of those viewpoints of what is the best care model. Okay.
In an ideal world, which I guess we never quite get to, are there things that the hospital could do that would help you, that we provide to you when we send you a patient? I guess specifically I'm thinking of the patient who leaves the hospital and they've had congestive heart failure, or maybe they have renal failure, or maybe they're a recovering pneumonia patient. Are there things that we should be considering as an industry that ought to be incorporated as a part of the discharge process that would help you better understand the patient? I just didn't know if y'all have any of that going on in any of your markets. That
I think there's a few things there. Part of it I touched on a little bit earlier was the diagnosis for medications, because they come to us. Sometimes medications have been changed in the hospital, and then sometimes the doctor will add to that continue previous medications, and you're trying to figure out what were those previous medications before hospitalization. So you're trying to put together that, and the diagnosis becomes extremely important for that medication, which is difficult for us because we don't have the history. And oftentimes the hospital can go back through, maybe they've been to the hospital several times, you can go back through the history and help us determine. That's also needed for their level 1, for their OBRA screening, is the history of those medications, and it's difficult without the hospitals assisting us. So that's one of the things I would say. And it comes back again to the side effects of medications, of the diagnosis and appropriate amounts and the side effects. That's very helpful for us to know. But it's also very helpful when we get shift report from the hospital to the facility to know what's going on besides what's just in the HMP. And sometimes we don't have the discharge summary for a few days after the patient gets to us. If there are wounds, if there's a catheter, things like if they're on oxygen, just so that we've got those things set up. Yes, we have oxygen in the facility, but it's nice to know to have it set up in the room when they get there. It's nice to know catheter and supplies and things that are needed. So that communication of what's needed from medical and to care for that patient makes a big difference if we have that communication when they come in.
Okay. Hollie, do y'all have any specific documents that come to mind that y'all send with the patient when they're going out relative to their disease-specific conditions, somewhat like you would perhaps send a patient home with certain expectations for the caregivers to watch when they go home, particularly, I guess, if they were a congestive heart failure patient, that, you know, watch for weight gain, watch for ankle swelling, watch for shortness of breath. Do y'all send anything like that with your patients into the post-acute settings other than home?
We keep a folder in their rooms, and anytime they're getting education throughout their stay, that education is going into their folders. So that folder should be going with them when they exit our building. But we also, part of our community meeting was we shared with all of the SNFs the education that we do provide our patients so that they would know exactly what we're giving those patients when they leave.
Can you describe a little bit about what that meeting, what it does, who is it with, what do y'all talk about?
It's with our home health agencies, you know, that we mainly give we refer most of our patients to, and our SNFs. We recently involved our DME companies to help with that too, and pretty much we call it our community care transition meeting, and we just meet on a quarterly basis, and we usually have an agenda, and we go over readmission data with them. We show them Marshall Medical Center's readmissions. We show them their specific readmissions too. We did hide that for a while, but we recently unhid that. So they know, they all can see what each other's readmissions are, a little competition there. They can see what everybody's readmissions are, so they know if they're good or if they're bad at Marshall Medical Centers.
I bet they show up for the meetings to make sure to see what the numbers are.
They do. And we also hand them their specific patients that were readmissions, so that they could go back and look at those charts and figure out what they may have missed on those patients. So pretty much it's a lot of data that we give them at first, and then we usually have an agenda. We're either going over education or we're talking about a new program that we may have. Our Joint Academy has been a big focus. We have a COPD team that we're starting, so we want them involved in that too, so that they know what we're doing at Marshall Medical Centers, so they can help us, because they're out there seeing them in the home and once we discharge them, so we want them to tell us stuff too. So really we just keep them up to date on what we're doing and ask them if there's anything we need to do to help them. It's a collaborative. I mean, we work together with them and them helping us too. So the agenda's different each time, but the data's the same. I mean, we show the same data components every time. Okay.
And I do commend them for doing that. I think sharing that readmission rate with the SNFs who are admitting to you is huge. We often take ours to our hospitals to try to show, but to see how you relate to others that are admitted to that hospital, I think that's wonderful sharing of information.
Okay. Could you share with us a little bit, because I suspect some of us, particularly those who have SNFs, you probably know the answers to this, others of us may not, but how is the medical supervision of an individual patient? I know that many of the nursing homes have a medical director. Is that medical director have greater authority than the private physician of the patient? How does the interplay between, I might have a physician that's for my loved one, and there might be a medical director. Who's kind of calling the shots about mama's care?
Okay. Every facility has a medical director. That's required by regulations to coordinate the overall care in the facility. Then the resident has the choice of attending physicians, but just as in a hospital, they're credentialed, and the nursing home has the right to say who can practice based on their own rules and regulations for credentialing. So as the medical director, they would have supervision over the attending physicians, and if any point someone does not have an attending physician that practices in that facility, then the medical director's responsibility is to take over to coordinate medical care for that person, or if the attending physician gets behind in seeing the patient. Most physicians now are headed toward nurse practitioners to also assist. We're getting more and more of those in facilities, which have been a really great asset to help physicians in rounding and seeing people in long-term care facilities.
Okay, all right, good. Holly, when you look at what's going on at your facility, I'm sure that, like many, everybody's trying to reduce length of stay. Everybody's trying to accelerate a discharge or making sure that the arrangements are made. Anything particular y'all done to be able to get, you know, Friday discharges, weekend discharges to post-acute providers, whether it be home health, be DME, SNF, anything that you're doing to engage that activity earlier in the patient stay that would be helpful for us to hear about?
Well, I'm sure we're like everybody else. We try to start that discharge plan on day one, the minute they hit the bed. But pretty much that's what we're doing. I mean, we're trying to see those patients. The social service staff, you know, even if they don't have an order on that patient from a physician by day 2, then they have to see that patient anyway and start discharge planning right then, and approach the physician, our physicians, and ask, okay, what are we going to do? You know, we've got to start getting this patient ready to go if there's something we need to do for this patient. So that's kind of how we're looking at it, because of course length of stay is on our radar too. I'm sure like it's on everybody else's radar. So
in your market, do you have facilities that will take weekend admissions, or are they basically say? Okay.
All of our facilities, our SNFs take weekend admissions.
Okay.
You know, we just
Same
try
with
to,
home health and DME. Okay.
We just try to get the paperwork ready to go on Friday. I mean, of course, we can't do the orders at that time, but we try to get their levels done, especially if we think they're going to be a categorical or anything. We try to get those levels done on Friday so that they're ready to go Saturday or Sunday.
Okay.
That's really the only hindrance, so to speak, to a weekend admission or a holiday admission is over screening office. If it happens to be closed, because you've got to wait on getting the level 1, and then if you run into level 2,
right,
it slows it down even more so.
Can you tell us a little bit about what that overscreening office, what does that mean? I mean, I think I know, but I might not.
Well, we probably don't like it any more than you guys do, but it's one of those things. It came about as part of the regulations when there nationwide became so many facilities for the mentally retarded and mentally ill closed, and then there was a big push, and they became long-term care residents. And the idea was that they should not be in a long-term care facility unless there was an overriding diagnosis of dementia or something else, so that we did not turn nursing homes into mental health facilities. So before someone is admitted, they have to have a level 1 screening done for that process. And from our end, what it means, and that's why we dig so again on all those diagnoses and medications to back up diagnosis, but if it's done inappropriately, we don't get payment. So we could sit there an extended period of time with an inaccurate one, which then could hold up our payment until it is corrected and it doesn't go back retroactive. So it becomes a real big issue with us. But I do want to touch just a second on them. I did talk about some of the changes that were happening, and one of the big changes, in addition to what I'd already mentioned that's happening with regulatories, is a real emphasis on behavioral programming and interventions, which is real concerning in this state to me, because I think that's something that we're lacking. The hospitals need to discharge people. If I look at my #1 reason for turning down admission, is behaviors. And I'm sure you guys have run into that too. We're not mental health facilities, aren't capable of handling. There's an additional emphasis coming down that. And we really don't have the programs and resources in Alabama to do behavioral, or I almost will say psych care. They're calling it behavioral, but it's basically psych type care in a long-term care setting. And I don't know where those patients are going to go.
Right. Well, I think we're all learning that the pipeline is getting very sluggish because they're either ending up staying longer sometimes in the acute care. We understand the rationale that you just described, but the problem is I think the state has essentially dumped this problem on the rest of us, and the state is yet to fulfill its responsibility from my perspective by providing adequate facilities in the state of Alabama. So that sounds more like a political statement. I don't mean it to be, but just from a practical standpoint, I see a lot of people stuck looking for appropriate placements, and there's just not a venue in which they're being received.
It's a real issue.
Yeah. When you were talking about the overscreening, is that something your staff does and you have to file it with someone, or is that strictly an internal document that you keep?
Well, it is a state document, federally mandated. It's typically started at the hospital setting.
Okay.
Now, if someone's coming from home, we start that document. But if they're in the hospital, because it's pre-admission screening, so
Okay.
it is done prior to admission to a long-term care facility.
Okay. All right.
Another thing I wanted to touch on, Keith, that we use at Marshall Medical Centers is it's called CareMatics, and it's one way that we're able to communicate with our referral sources, our SNFs, and our home healths. And the social workers are constantly communicating through CareMatics. They can push out the patients, once the patient makes a choice, of course, of who they want, they can push out the referral information through CareMatics, and then it's secured messaging. So we don't have to be on the phone with them 25 times a day. If they need something else from us, they just message the social worker that sent the referral and says, hey, I need this, I need an H&P from when they were there 6 months ago or whatever, and we can shoot that right over to them, and they're able to get that information. So it makes our referral process very quick, easy and quicker on both sides, and we're not on the phone constantly tagging each other, trying to get information.
I know on the hospital side that, Hollie, y'all probably spend a lot of time with your present on admission assessment of a patient who presents from any number of venues, could be home, could be from another facility. Anything special y'all have had to do, or anything you've revised as a result of trying to handle your hacks and keep your adverse events responsibility down to those that you truly feel responsible for? Anything you're doing special on those present on admission assessments in the nursing area?
Not that I'm aware, not that I'm involved in.
Okay. All right. Anything on the other end, Carol, when you get a patient from the hospital, do y'all assess the patient very deliberately to make sure that there's no pressure ulcers, identification of infections, identification of an abused situation? I'm sure there are things you do to make sure that if you're going to be held accountable, that you know what you got when you got it, that you didn't inherit it from somebody.
Absolutely. A weight, a height, vital signs, thorough body audit, all of those things upon admission.
Okay. All right. All right. Well, I'm running kind of low on the questions that I had thought of here. So let's open it up to those of you who may at this point have identified something that you'd like to know while we got these experts sitting in front of us. Any questions from the group? Okay, go Lydia.
What tools do you have in place at your organization so that when the phone call comes from J.P. Morgan about transitional care, they can answer those questions supportive of the hospital?
Okay, I don't know if y'all heard the question. I'm going to try to repeat it just so that everybody can hear it. And Lydia, if I don't get it right, help me out. She was asking what tools I believe Hollie has at the hospital, particularly as it relates to the transition of care, similar to the calls that J.L. Morgan and them are making. And I will just say before Hollie answers, I think there are a lot of hospitals who have tools. Many of them may be contracted vendors like that. In other cases, I suspect that hospitals either don't have tools, or either it's a self-call mechanism that they have inside their institution, is what I think we might hear. But Hollie, any feedback from your facility?
Well, just so happens, J.L. Morgan does do our phone calls, our follow-up phone calls 24 to 48 hours after discharge. We recently asked them or got them to start doing those, I would say 6 months ago, maybe. So they make those phone calls for us, and if they have any alerts, any of those alerts that he spoke about earlier, and even if it's transitions of care, they send us an alert email immediately and let us know those. And so at that point, it goes to one of our social workers and to myself, and we go in and look at that alert, and then we pick up the phone and call that patient ourselves. And we say, okay, we understand you didn't get your medicines today, or you know, you didn't, your home health hasn't come, or whatever is going on with that patient, and we try to resolve that at that point right then.
Okay. Other questions out there?
You're welcome.
I have a question. This is for the long-term care setting. What type of education do you do with family members when you say you have those difficult ones that's demanding that mama goes back to the hospital? Is there education done up front? We can treat urinary tract infections here, that type of stuff.
I'm going to repeat the question, if it's all right, before you do it, just so that we have it picked up on the video here. And again, if I get the question wrong, you correct me. I think the question was for Carol, is what did they do in their institution regarding education with the family members to let them know what they can treat in their facilities, example being a urinary tract infection, et cetera. What communications the family might have participated in relative to those?
Upon admission, there's meetings with families where we're going over what we can and can't do. And we do that from a care perspective all the way down to things that shouldn't be in their rooms, and all the way up and down the line. Sometimes my concern about that is we're covering so much in about a 2 or 3 hour period. You wonder, overload, because as I often tell my staff, they've been at the hospital, they've been up for a week solid, sitting up with their family member, and now we bring them in for a 2 or 3 hour orientation session. So sometimes I think we're information overloaded at that point. But we still feel it's important to do as part of the mission process. Then there's a care planning process where they come in at the end of the first month and then quarterly thereafter, or whenever the condition changes, we're on the phone, we invite them in for care planning sessions to update care, to talk about things, family nights, education seminars to try to keep them educated on what's happening. Another interesting aspect of what's happening to us that as part of this November the 28th, why November 28th, but that's the magic date CMS chose, is called a facility assessment that every nursing home in the United States has to do. And that is a very detailed, encompassing facility assessment on staffing. As you well know, there's no minimum requirements for staffing for long-term care in Alabama, but this is staffing ratios, requirements for wings, diagnosis, a listing of what the facility, the type residents they will take, including the education of the staff to take those diagnoses, equipment needed. It's a very, very detailed assessment, and when the surveyors come in for our annual inspection, we will give them our facility assessment, which is about a 100-page document of what all the facility is assessed and can care for. Even includes a financial component for them to use as part of their survey process. So it's a very detailed, but it also encompasses some of that too, of what you've done to train and educate. So let's say the facility then decides they can take something they've not normally taken before, like dialysis or a type patient they've not normally taken. They take their facility assessment and update it with all of the skills and training and education that they've done, as well as an assessment of staffing levels that's needed to be able to take that new type patient.
Okay. I did. Okay. Any other questions? Right over here.
Not maybe so much a question, but just some lessons learned in my EFPS life in South Carolina. We had developed a community collaborative similar to what you described, and a couple of barriers that we had identified were, especially for weekend discharges, was around pharmacy availability for medications. So we added a couple of community pharmacists to our community collaborative to help with that, break down those barriers. In addition, the discharge instruction
I don't know if all of you could hear it. I'll try to repeat it, but again, invite you to please correct me if I miss it. I don't know that I'll make it as an interpreter, but her point was some lessons learned in South Carolina that one of those is they had a barrier to there being pharmacies available on the weekends, and they worked in the community to address that. And then secondly, trying to make sure that the assessment of the appropriate disposition was something they worked on to try to standardize some of that, if I heard that correct. Is that pretty close? Okay, all right, good. And it reminds me, and that was part of the question I was asking earlier, and I couldn't remember if it came out of some of the AQUAF work or not. I know that we had a lengthy discussion once in one of our quality task force about how helpful it might be if we could come up with some of the key discharging diagnoses, like congestive heart failure, I guess was one of those, and in terms of trying to put together a packet of information or a sheet of information that just says to your staff, if it wouldn't be insulting, that if you start to notice ankle swelling or you start to have weight gain, trying to get a proactive action that would perhaps be resolved prior to the patient having to come back to the hospital for those conditions or circumstances. And I don't know if anything ever came out of that work with AQUAF. If anybody ever saw that, have you seen anything like that?
But we do use those. We do a plan of care. We start it within a few minutes of a resident being admitted that does take into account their diagnosis, their medications, fall risk.
Do you know if that's true in most all of the facilities, or primarily just yours?
I think that's becoming the norm now.
That might be something we'd love to know more about. If there are samples or something that maybe Rosemary we could get to know what is being used, and then if there might be something that the hospitals would have some input, or physicians might have some input on, if y'all were open to that.
There's one thing I forgot to share that I think has been huge for Marshall Medical Centers is when we have a patient going to a SNF for rehab, we have started going ahead and getting them to make their choice for what home health they may want after going to rehab. And so at that point, we go ahead and make the referral to the SNF and then to whatever home health agency they want to use. And what is happening is our home health liaisons are going in and seeing those patients in the SNFs while they're in there, so they're becoming familiar with those patients and kind of knowing what's going on with those patients while they're in the SNF before they're discharged home. So that's been a big thing. Our home healths have seen a big improvement. Our SNFs have seen, improvement of the patient's care, because it's just a continuancy of the care.
And to dovetail into that, what we're doing as a company is when they're going to that home health, then there's that 30 days that they can still come back to us and get back on their Medicare coverage. So we're still staying in touch with their in-home health, asking them how they're doing. Are they doing okay at home? If not, do they need to come back for a few more days of rehab, get a little stronger, and then go back to home health, so that we're then helping the hospital by not readmitting.
Right.
If they can't make it in home health, then they can go back into the skilled nursing and still get Medicare coverage.
That sounds like a great step out there. Anything we haven't asked that came across your minds that either of you would like to add here at the end?
So I think Rosemary.
Oh, got it.
Sorry.
All right.
One of the things we talked about in the phone call was NDROs and how that's handled and some of the capabilities of the skilled nursing facility. We got into that whole conversation. Can you share a little bit about how nursing homes are ramping up their infection prevention efforts and what, that type of thing?
Rosemary asked her if she could speak basically to how the nursing facilities are elevating their work in the IP arena, I guess.
Once again, as part of all this additional regulation, there's a lot more emphasis on infection control and prevention of hospital acquired, which we're also hospital acquired when they happen in our facility, or healthcare acquired, I should say, rather than hospital acquired infections.
I like that a lot better. I'm going to start using that even in the hospital. I'm going to start calling that.
It's more appropriate to me. And part of the next phase of our CMS requirements will be to actually have an infection control practitioner in every facility. So it will be a position that we will have to add at our facilities. Interesting, they've added the regulations to go into effect November this year, but we don't have to add the staff member to next year. It seems like you need the staff member to help you do but you know,
Wow.
go figure how CMS does that. But a lot more emphasis. We've already got programs set up of trending and tracking, making sure that we're using antibiotic stewardship, that we're appropriately giving antibiotics. Once again, we're kind of in a sector of society where they feel like an antibiotic, well, is what's needed for everything.
Imagine.
And that's the real teaching of the families, is to try to teach the families that an antibiotic's not needed if you don't have the appropriate backup for that.
Some of you in the audience probably would know this better than I, but are you going to have any specific certifications for these IPs?
Yes.
So we're fixing
Yes,
to take what is a limited supply of people, probably across the nation, particularly in Alabama, and you're going to be recruiting, and we're going to be trying to retain a very limited supply of people. So it sounds like there's a tremendous need for new people to be identified and trained right away. If y'all are going to have to do that, and we're going to have to try to continue to do what we're doing. That's interesting. CMS would put us in that position. So does that make sense, or is that where we're headed? Wow. Okay. All right. Anything either would like to mention? Well, again, thank you all very much. We're going to conclude the day. Let me just again remind you that if you want to get CEUs or CME, please stop by the desk and do that as you leave. I want to thank everyone who participated in the program, and thank all of you for being here today, because this is what makes these meetings effective. And good, safe travel home. See you next time. Thank you all very much.